To kick us off, we have Dr. Kim Workowski, who's here at Emory. She is a professor of medicine and infectious diseases, and she's spent her career studying sexually transmitted infections and is really international expert. She serves as consultant to CDC. She's on the guidelines committee for STIs. She's also on a number of other federal guidelines committees. She's in charge of making recommendations about post-exposure prophylaxis with Doxy. So all kinds of things that she's going to talk to us about, basically what's new in the management of STIs, but I'm sure in the Q&A she'd be happy to delve into whatever she didn't have time to cover in a 30-minute talk for a 30-hour disease condition. So welcome, Kim.
Thank you, and I heard you guys know everything about Doxy-PEP. So I will tell you my thoughts and some reservations that you should have as well about who you should use it in and some of the cautions. So these are my disclosures. First, what we'll talk about before we get started is, as you all know, because you're experts, is that STIs don't happen in isolation. When we think about STIs, we have to think about other things, including substance use disorder, viral hepatitis. There's currently an ongoing syndemic, and what you see on the right is the federal guidelines that kind of came out singly instead of together. That's a problem that I have because there's really a syndemic. When we see one STI or we see HIV or substance disorder, they kind of can all occur together. WHO has a document that's very nice. It integrates all these different syndromes and infections kind of together. The other thing that's challenging for all of us is infections can be asymptomatic, they can look different, they can travel, and they travel in pairs, or, you know, they all travel together. So it's when you see one, you have to test for others. We have emerging antimicrobial resistance in gonorrhea and Mycoplasma genitalium. I won't have too much time to talk about MGen, but happy to talk about it in the Q&A. We've also had problems during COVID with reduced workforce hours. We had shortages of antimicrobials when everybody was using azithromycin for COVID. We've had problems recently. We'll talk about the benzathine penicillin shortage and what to do. And then also for us on the front lines, there's also limited point of care diagnostics when somebody presents with an ulcer or a urethritis. We really can't do much at the point of care, which is a big problem. So what I list for you there, you can go back at your leisure, is the tests that are FDA cleared. And we see chlamydia, gonorrhea, and trichomonas. Some of them are CLIA cleared, some of them are not. And then we'll get to syphilis. We'll talk about the direct tests that are available for syphilis. So again, I don't have to tell you all of this in terms of the prevention, but what's important here is remember just something simple. Remember the 5 Ps to ask about: partners, practices, protection, past history, and pregnancy intention when you're interviewing somebody. Also, when you're doing your health assessment, again, we want to intermix STIs with our discussions about depression, substance use, intimate partner violence. You're going to screen per guidelines. What I list for you is the guidelines from the U.S. Public Service Task Force. There's behavioral counseling guidelines. There's also guidelines from CDC, dependent on which population that you're screening. And I list there for you all the specific guidelines from the U.S. Public Service Task Force, including syphilis, gonorrhea, neonatal ocular prophylaxis, and all the hepatitides, just to remind you that those are all available to you. The importance of vaccinating as a primary prevention tool for both hepatitis A, B, and monkeypox. We're not doing so good about vaccinating. Our numbers in terms of vaccinations have really gone down with Mpox, and Mpox is starting to go up again. And there's some emerging data that those who are vaccinated that were not infected, the immunity may wane. So it's really important to get people at risk vaccinated. And then we'll talk a little bit now about the prevention methods in terms of what's currently available. This is a very busy chart, and I'm not going to go over it. This is just to say this reference you should get and read. It's a reference on all the current trials that have been published on post-exposure prophylaxis as well as the ongoing clinical trials. So it was just recently published, and I think it's really good because it talks about the populations that were tested and all the data, and it has it in one table. It's also in your references that I listed, but it's really important because there are differences in some of these trials, and it's really important to interpret the data that you have it all in one place. So let's go to the data really quickly, and I'll show you some of the data that was presented at CROI and some of the things that we need to keep in the back of our mind. It's simple to push a tablet to somebody and say, or somebody comes in and say, I want Doxy-PEP. It's important to think about the implications of using the drug. How much are you going to administer? How many pills you're going to give? How many refills you're going to give? And thinking about if your patient is at risk. So this was the first trial that was done a number of years ago, and it was a sub-study of the IPRGAY trial, and it was basically taking men that were on HIV PrEP and giving them doxycycline 200 milligrams to take 24 to 72 hours after condomless sex. And there was a dramatic reduction that was seen in chlamydia and syphilis, but not in gonorrhea. The thought was at that time, this trial was held in France, and France has a baseline resistance of tetracycline resistance around 70%. So there was thought that maybe it didn't work for gonorrhea because they had a high baseline prevalence of tetracycline resistance. The other interesting thing that came out of that trial was if you look at the people that got STIs in that trial, there was a small subset that were what I call the reoffenders or the frequent sexual STI frequent flyers, right? So there's a small core group of people that really resulted in the majority of the STIs. So that's what you you start to need to think about is how people are using it, and think about the data that actually the data that was actually generated. And when you think about, again, look back at the trials and see how many tablets were prescribed. Are you using it as PrEP or using it as PEP? In this trial, they were given 3 tablets a week and not daily. Some people are requesting daily use, which is actually not post-exposure prophylaxis, but PEP. Also, a couple of years ago, we had the results of the Doxy-PEP study. And basically at CROI, they presented some of the open label extension data, but this is just showing you what happened in the Doxy-PEP. That was the study that was done here in the US, in San Francisco and Seattle, and with the same eligibility criteria, men who have sex with men and transgender women that were at risk, and they were randomized to either Doxy-PEP 200 milligrams after sex or no PEP. And you can see there was a dramatic reduction here in the US in all 3 STIs, chlamydia, gonorrhea, and syphilis, but not as much in gonorrhea. And the effectiveness was independent of HIV serostatus. So this was the data that was presented at CROI, which is the open label extension after the initial Doxy-PEP study. And as you can see, there was a sustained reduction in STIs over time. But if you look, that again, we're having the most bang for our buck in chlamydia and syphilis, and gonorrhea is lagging a little bit, and we'll talk about why. If you look about the sexual behavior, what behaviors were going on during the randomized versus the open label, you can see there was a difference in number of sex partners, number of sex acts, and receptive sex. So there was an increase in risky sexual behavior associated with Doxy-PEP, but there was a continued decrease in acquisition of chlamydia and syphilis. The third study which was presented last year and then presented in finality at CROI, was the Doxy-PEP study. So if you look at the top left panel, you'll see it's kind of complicated, but it was a 4-arm study. You either got Doxy-PEP, you got Doxy-PEP plus a meningococcal B vaccine, or you got the vaccine alone, or you got nothing. And basically, we'll get at why this is important in terms of the meningococcal B vaccine, but you can see on the first panel on the right, there was, again, a sustained reduction in chlamydia and syphilis. Gonorrhea, there was not a statistical difference in terms of gonorrhea. And then what I list for you in the panel on the lower right was the proportion of tetracycline-resistant gonorrhea. This trial lasted a year. And in that period of time, you can see the dramatic increase in tetracycline resistance that has happened with just a short period of time of using Doxy-PEP. For looking at the meningococcal B vaccine, the efficacy outcomes were not significant, and that was probably based on the numbers. The numbers were really small in both arms. But there was no significant effect in this study on using meningococcal B vaccine. Why is that important? Because the first panel on your left, there was a trial that was done in New Zealand. There was an outbreak of Group B meningococcal vaccine, Group B meninge, and the public health authorities decided to vaccinate the population, right, because of the outbreak. And when they vaccinated the population, they found that there was a 30% decrease in gonococcal incidence. And what was interesting in this study, not only was there a 30% decrease, if you had concomitant chlamydia, there was no benefit. So there's a known interaction between chlamydia and gonorrhea, so the vaccine didn't appear to work in those that had concomitant chlamydia. The panel on your lower left here, you can't really see well, but this was data that was done in a mouse model that showed the same effect, that infecting mice and vaccinating them, you had an effect. So we have an in vitro model that shows that there's an effect. We've got this initial data from New Zealand, and then what I list for you here is all the trials that we've got going on looking at this vaccine ongoing worldwide. We are doing a study at Emory of comparing the use of meningococcal B vaccine versus placebo. We're part of a multi-site study. We're almost fully enrolled. We just had a DSMB meeting, and we were told to continue, so that's good. There wasn't a futility sign, and plus our N is a lot larger. It's 2,200, so more to come on that. But there is some biologic plausibility that has been demonstrated in observational studies, in an animal model, and we have all these ongoing studies that show that there probably is some effect. And why does it work? Because there's about a 99% homology between Group B meninge and gonorrhea. And so there's also biologic plausibility. This is from a poster that we presented at the European ID meetings last year, showing kind of the proposed mechanism of action. You say, well, what is taking all this data together and all the retrospective observational studies? The data is anywhere from 30 to 46% efficacious in retrospective studies, so we're really interested in what's going to happen with the prospective studies. But even 30% decrease in gonorrhea rates is huge on a public health basis. So more to come. So that's the importance of meninge B. Getting back to Doxy-PEP, there was also implementation studies that were shown in San Francisco where they have adopted the use of Doxy-PEP very early on. And 13 months after they kind of went all in for whoever wants Doxy-PEP, they observed significant decreases in chlamydia and gonorrhea, but chlamydia and early syphilis, but they actually had an increase in gonorrhea. So again, gonorrhea continues to be a concern. So more and more data. What I have on the right side of the screen for you, and again, these are 5 recent publications talking about our concerns. One of the things that you know is that bacteria share DNA together. And there's evidence that you can share the resistance elements from people that have a gonorrhea in their gut and can share with other enteric organisms. So you basically can pass this to other enteric organisms, the tetracycline resistance, and you can also, because the resistance genes kind of travel together, you can pass along beta-lactam, quinolone, other cephalosporin resistance together, as well as tetracycline. So things come at a cost. You have to be very cautious, and we don't have a surveillance system in place yet, but something to think about in terms of tetracycline resistant, the transmission of tetracycline resistant to other gram-negatives. So the evidence that I showed you, we have efficacy from 3 trials that this approach works in MSM and transgender women. There was a trial that was done in Kenya in women, and there was no efficacy. There was some thoughts that it was most likely related to adherence issues, but their adherence measures were based on looking at Doxy levels in hair samples. And when you're taking things intermittently, we don't have good data on what that really means and how to interpret that. There was some preliminary evidence that was issued from CDC about this guidance. I can tell you that the current guidance is now at the MMWR. Hopefully it'll be out by May or June in terms of the formal recommendations. But the implementation is where the problem is, right? In terms of how much to give, is your patient continually at risk? Should we have restrictions on who we should prescribe to, or should whoever asks for it, we should just give it to them? How much should we give? Should we give 3 a week like was done in the trial? Should you give 3 refills and just say, see you later? Those are the things you have to consider on an individual basis. My issue is that we should all still be antibiotic stewards. I am not satisfied with saying give somebody 30 pills and 3 refills. The issue is you have to individualize this, and you have to realize what's going on in the community. Is there sharing of antibiotics going on? So again, I want you to be cautious. This intervention works, but you need to think of the downside as well and really think carefully about what you're doing. It should be something with shared decision-making, not based on an SOP. Also, people should still be able to come in every 3 to 6 months and get screening, right? You can't forget about screening. This is not 100% efficacious. The other implication is what happens if, we know it works against syphilis, but what happens if somebody takes their Doxy-PEP intermittently and then acquires syphilis? How are you going to interpret their serology? So that's the other problem that we don't know. Somebody that loses their pills and they present with syphilis, and then you're trying to interpret this titer, and they may have a weird presentation. So sometimes it's very challenging. So I could talk a lot about Doxy-PEP, but let me just finish. Let me just show you some other things that you need to think about. The panel on your left is a study that was done in the 70s in our military, where the same approach was used using minocycline. This approach lasted 6 months before they had a huge increase in tetracycline-resistant gonorrhea, and the practice was discontinued in our military. This is looking at the one on your right, the panel on your right is from the study that was done in women in Africa, and there was no difference in the incidence of gonorrhea because there was 100% resistance to tetracycline. So why this is important is because it depends on where you have tetracycline-resistant gonorrhea isolates. This was shown at CROI in terms of the distribution of tetracycline-resistant gonorrhea throughout the world. And here in the United States, we have about, it says 65, that's a little high. Our current numbers are about 35%, but you can see how quickly that can go up. And if you take care of clients or thinking about this in other parts of the world, you need to think about what your baseline tetracycline resistance is. So, all that to say, in terms of implementation, restrictor versus broad, who's your eligibility? Should you stick to what's been in the trials, which is MSM and transgender women? The current guidelines, the country guidelines that are available, are inconsistent. Should you worry about your population level, or should you think about it on an individual level? Think about antimicrobial stewardship. We have to do a good job of, if you're going to be doing this, thinking about how many pills you're getting. I mentioned about the problems with the syphilis serology, how you're going to manage contacts. And what about women? Even the trial that was negative in women, biologically it should work, but we have no trial evidence to support it. So how are you going to handle women if a woman wants to be on PEP? What's the impact on the microbiome? And we have to do a good job of thinking about current surveillance systems. How are we going to surveil this? There was if you look back at the Doxy-PEP study, there was a small increase in tetracycline resistance in Staph aureus. We use a lot of Doxy, right, for Staph aureus. So how is this going to potentially influence our skin and soft tissue kind of algorithms? And then GC resistance, we need to really have a handle on what's happening with tetracycline resistance. So I'm going to quickly move to syphilis. And you've heard a lot. I know you saw some wonderful pictures by Dr. Sag this morning. Two things I want to share about syphilis. This is from the most recent surveillance report, and it's really fascinating, the differences in how people acquire it, MSM versus women. You all know that there's been an epidemic of syphilis. What you may not know, there's an epidemic of congenital syphilis, because there's been a spike in the last 6 years in women getting syphilis. So you look at the difference in behaviors, right? So what we see in MSM, it's sex with anonymous partners, and for women, it's sex while intoxicated or on drugs. So there's a difference in terms of behaviors, right? In terms of how syphilis is acquired, whether you're a man or a woman. Two good articles that you should get. One is by Khalil Ghanem in the New England Journal. It's the best review article on syphilis that talks about the stages. It's wonderful. One thing to mention here that's really important is it's not linear. You don't go primary, secondary, early, latent, latent. You can go primary, secondary, back to primary, secondary to early, latent, back to syphilis. Syphilis is confusing, and it continues to humble all of us. 3 pictures here down below for you to look at. White patches, mucus patches in the mouth that were unnoticed. The middle picture, the nose, this was a sexual assault in the face. And this was syphilitic chancres on the nose, and the difference in the rashes, right? The rashes can be anything. Another good article, Mark Hamill from Hopkins produced a wonderful article on the National History of Neurosyphilis, which is, again, very confusing. I don't have time to go into it, but it's wonderful. And then we also think about, we're seeing an increase in cardiovascular syphilis as well as cerebrovascular syphilis. Congenital syphilis is a problem. We had the opportunity to publish this paper a couple of months ago talking about the epidemic of congenital syphilis. It's just devastating. We've had the highest numbers we've had in 50 years. And so this is really an important paper to think about what our problem is with congenital syphilis. And we're thinking about what the epidemiologic risk factors are, include co-infection, as I talked about before. There's disparities in race, people that haven't gotten prenatal care, but this is the most important to me. This is the cases that may have been prevented. 51% no or inadequate treatment. That's unacceptable, right? Or 37% no timely testing. So people aren't accessing care. We have a problem with getting benzathine. And so they don't know where to go. So we have to think out of the box. Non-traditional settings, increase implementation of point-of-care tests. We have 2 of them. They're not perfect, but there's 2 of them that are available, that we need to do a job to think about people that are in situations where difficult to access. And we need to get out there and start giving people treatment in the field again. A couple of things that you need to be made aware of is that there's new CDC recommendations for syphilis testing that were issued by the CDC, as well as a nice WHO point-of-care diagnostic testing, which is wonderful, but it's mostly for people that don't have diagnostics, because they have to take care of countries where they treat these infections syndromically. The other thing that's up and coming is a PCR. We have PCRs for everything else. There's not a commercially available PCR for syphilis. But what's interesting in a sub-study that we did in a syphilis treatment trial, this is looking at patients that presented with primary, secondary, and early latent syphilis. And I want you to look at the percentage of people that had an oral swab that was positive in early latent syphilis. So in what this data says is that syphilis, again, we know it's disseminated, but it says a lot for transmission. So even if you don't see a lesion in somebody's mouth or somebody's anus, there's a good chance that they've got treponemes hanging out there, and they can transmit even though they've got no lesions. So this is really interesting. We're just learning a little bit more about this, but this is going to be really interesting in terms of transmission risk. The other thing that's new is I put down here who we should screen for syphilis, but you may not be aware that there has been new recommendations to screen anybody sexually active age 15 to 44 in counties with a high prevalence of syphilis. So the other bullets there we already knew about, but will include a lot of people, and this is the kind of the map that shows where the syphilis hotspots are. And of course we know Atlanta is a hotspot. But this is just important here that you may not be aware of this. You may be aware of other people we should screen, but again, it's based on prevalence of syphilis now. So we still have a problem. We don't have great point-of-care tests for syphilis. We don't have those commercially available PCRs yet. We're stuck with these serologic screening algorithms, which are problematic, right? One of the important things, the most important thing on this slide is what's in red at the bottom. You don't diagnose syphilis by a blood test. It's in combination with what you see with your patient and trying to figure out, do they have primary, secondary, or early latent, and especially in primary disease, if they present with an ulcer, you think it's syphilis, your RPR may be falsely negative 30% of the time. So that's the other reason in some of these instances to not only get an RPR, but get a treponemal test at the same time. Some of you may have reflex testing where you go from an RPR to a TPPA or some other treponemal test. But this is important to think about. Okay, a couple of updates on syphilis treatment. Traditionally, we've been giving benzathine penicillin, and we've been telling you to give one shot for primary, secondary, or early latent disease, whether they have HIV or not. And some people have been listening to that. Other people are just trying to be conservative, and they're trying to give people extra benzathine in the absence of data. So we actually have data now. So there was a randomized trial, 1 versus 3 shots for early syphilis, and you can see the response rates maybe not be as high as you think they should be, but it was only based on 6-month follow-up for this initial cut of the data. The bottom line is there's no difference in 1 versus 3. So we now have RCT data that confirms they only need a single shot. The other important information on this slide is there's a lot of co-infection. If you look down below, 1/3 of patients had chlamydia and gonorrhea. So if you see syphilis, you need to look other places. We have a benzathine shortage. And the benzathine shortage is because we have increased demand, there's increased numbers, there's a problem with there's only one plant in the United States that produces this, and there was a problem with manufacturing. When is this going to get better? They keep moving the date back. The latest I heard is the 4th quarter of this year, but my guess is going to be moved back. So what the government did was they went to France and they imported exicillin, which is very similar to benzathine. I list for you the websites. What's different, though, and what you need to know, you have to reconstitute it, and it's more volume. You know, it hurts like heck to get it in your butt. But this is twice the volume, okay? The other problem is we're having some of you who give 2.4 sometimes just split it up, right, and give 1.2. We can't find 1.2, so everybody's getting 2.4 if we do have benzathine. And then exicillin is a potential option, but it's an increased volume. So the other thing that's happening is we have now a model where we're able to grow syphilis in the lab and look at other antimicrobials because we have a problem with benzathine, so let's look to see what's available. So there was a alternative syphilis workshop I went to a couple months ago at NIH, and I wanted to give you an idea of what's being looked at, what's in the guidelines for early syphilis, is either ceftriaxone or doxy. These other drugs are being looked at, either in trials or and you look at that and you go, what, linezolid? Yeah, linezolid was studied, but the dose that they chose was not right, and it didn't work. They only gave 600 milligrams, not BID, but just once a day for 5 days. For neurosyphilis, we have ceftriaxone and procaine. However, procaine is not being manufactured anymore because the company that makes procaine also makes benzathine, and they decided to put their resources into benzathine, not procaine. So there's a trial design right now of thinking about what an option might be for neurosyphilis. So the current the current iteration of the draft is doxycycline, 200 milligrams BID versus IV penicillin. Linezolid is being looked at as well at higher doses. I'm going to quickly, because my time is up, but I'm going to quickly go to tell you what's important about gonorrhea, and that's the emergence of disseminated gonorrhea. And the epidemiology has changed. It's occurring in men, older men, and illicit drug use. We've also had 3 cases at Emory in the last year of patients that have had gonorrhea endocarditis. This endocarditis is like none other that you've seen, and is that it's very destructive. The one that still is very challenging, I put down here male, 17-year-old male with PID, trichomonas, aortic root abscess, and this was the first time she had sex, and unfortunately she died of gonorrhea endocarditis. It was horrible. Still haunts us to this day. It was a horrible thing to watch. But this organism really chews up vasculature. So again, think about weird presentations. We're seeing more and more of disseminated gonorrhea. We have a problem, I told you, with antimicrobial resistance. Remember that our recommendation now for treatment of gonorrhea is 500 milligrams of ceftriaxone. You give them doxy if you have not excluded chlamydia. And we have weight restrictions now on this. If your patient weighs over 150 kilos, they need a gram. For chlamydia, the only thing I'm going to mention is we all know that we're not using azithromycin anymore. Doxycycline is the drug of choice. And my last slide about the duration of treatment, we don't know what the minimum duration of treatment is. So we have decided to do a study to investigate that. There's some initial literature that a single dose of minocycline was effective. There was an RCT that was done about 20 years ago that showed that shorter course might work. So we're doing a definitive study in women and men of 3 versus 7 day. So I'm going to stop there and tell you that this continues to be a problem for us. There's variable presentations with profound consequences. Think about what's coming. There's innovations in diagnostics, alternative treatments, care delivery, and we really need to target our interventions to our populations and meet them wherever they are. Thanks so much.
Well done, very comprehensive. We have a number of questions and not that much time, so I'll do
I
the
know.
questions quick, and we'll have the answers quick and get through what we can. So the questions about Doxy-PEP, and what about for women? What was your final, in San Francisco, they're treating pretty much everyone.
I know, they're very broad, they're treating everyone. So I can tell you that the guidelines from CDC are going to be based on the data. And the data are, I already told you what the data are. So it's up to the individual provider through shared decision-making. That's the wording. I mean, guidelines should be based on data, and then if you want to go to a gray area, you have to decide that with the person in front of you, which I think is fair.
So in other words, you recommend treating women? I'm kidding, just, yeah.
I recommend shared decision-making.
All right, good, real quick.
Doxy-PEP for patients. It's very difficult to convince them that it's not necessarily a good idea for them. You know, I'll have patients that come in wanting it and they've never had an STI in their life. And, you know, it's a discussion, right? And sort of these are the risks, and there is a risk of this growing antibiotic resistance and all this stuff. And they say, yeah, okay, but I'm gonna take it anyways, because like that's what I want. And so I'm just wondering, like, how do you go about having that conversation? Because in my experience, if you say no, they just go somewhere else or they borrow a friend's.
Well, so they're going to continue to borrow it. They're having, you know, they're having M&M parties, but instead of M&Ms, it's Doxy. And I mean, this is from patients telling me this, right, in terms of what's happening out there. I think that I just do it individually with the person, and the way I handle that, if they're very insistent about it, I give them a couple of pills, and I said, here's a couple of pills, see how you do with it, and let me know. And so you give them, it's kind of halfway, right? So you're giving them a defined number of pills, and then it's negotiation. You know, it's basically how much did you use in a month, and if you've got a patient portal, that's how I handle it. It's a little different on a public health, so think about what public health has to do, you know, where they don't see those patients regularly. I say think about it like HIV PrEP. You know, that you give them a defined amount, you have them come in, you have them be screened. And that you're gonna have to base that on what you can kind of figure out with your patient. I don't have a great answer, because you can either be really restrictive and stick with the data, or you can do what San Francisco's doing, which is basically whoever wants it gets it. And I think the answer is probably, my personal opinion, I think the answer is somewhere in between. And that's difficult to define.
So real quickly, can you explain how Doxy-PEP would impact syphilis serology?
Yeah, so the issue is if you acquire syphilis, and we don't know, we don't have data on doxycycline per se for how much doxycycline you need to prevent syphilis. Okay, and say, you know, if you have multiple partners and you're using 5, 6 tablets, the issue is and they come in with a titer of 1 to 2 or 1 to 4. The issue is, could it affect the titer at the get-go? Yes. Could it affect the titer if you do see somebody that your titer may not be high enough and you're trying to interpret a titer fall of a 4-fold decline in titer? It may affect that. Give you an example, a really quick example. There was somebody that was diagnosed with syphilis. He got Doxy for something else because he had chlamydia, but he lost a couple and he had a titer of 1 to 64. This is somebody that they just told me about this case. Titer was 1 to 64, also had chlamydia. He took 2 tablets and he lost the rest of his prescription of 14 days. He comes back in a month and his titer is 1 to 4. What would you do? His titer is 1 to 4. He had syphilis, he had lesions, he had chlamydia, but his titer had dropped to 1 to 4 in a month. You have to treat him. He didn't get adequate treatment for syphilis, so you have to get him benzathine, right? Is the point. So that's what I'm talking about. Sometimes it gets messy, or the presentations may be different. They may be muted, or the other concern is if people start having more neurologic manifestations. So we just don't know all the answers, is the point. Syphilis serology is incredibly difficult, and I think it gets more difficult when people are intermittently using drugs that have activity against syphilis. It's just hard.
Here's a question about, should we be testing and swabbing for Neisseria meningitidis pharyngitis in symptomatic young MSM?
No.
Okay. Can the answer, I think, for this one's pretty clear, but worth stating. Someone has neurosyphilis, they get admitted, they get IV penicillin, 14 days, they're discharged. Do they need benzathine afterwards?
No.
Right.
That it's optional.
But probably not necessary.
No, because we have a benzathine shortage. It needs to be for the people that have
Yep.
early syphilis, and stop giving people 3 shots for benzathine for early syphilis when their CD4 count is 10, and you're nervous that they don't have an immune response. There's no data that supports that. So we got to stop that. We're treating ourselves instead of the patient. So stick with the data. Just give them a single shot of benzathine.
So this is a common dilemma. It's got a serofast patient. Let's say it's high, like 1 to 128, at-risk person, but who was treated more than 12 months ago for syphilis, and it's just been hanging right there. Do you retreat?
Depends on the person. It's a great question. We don't know the answer. If they've had 30 partners and you don't know, you can give them a single shot of benzathine. Would I give them 3? No. If you're HIV positive, remember that if you read the CDC treatment guidelines, that for people that have HIV, that it may take 24 months for that titer to drop with early syphilis. So that was a change in 2021. A lot of people don't know that. So that it may take longer to drop their titer. So to me, it just depends. You talk to the people if they're at risk and you can't tell, you either watch it or you give them a shot of benzathine and then you check that titer every 3 months.
Yep. And how often, I think you just answered, but if you have somebody who's post-treatment of syphilis with Doxy, do you monitor every 3 months afterwards?
The recommendations are every 6 months for somebody that does not have HIV. It's every 3 months for HIV.
Great. I think we got through them all. Thank you so much.
You're
well
welcome.
done.